The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Good afternoon, everyone. This is a privilege to talk about a program that I think will be helpful to many. Autism, as we know, is a complex disorder, and this presentation deals with the evaluation and treatment of individuals on the spectrum using a multidisciplinary approach called the LADDERS model. LADDERS stands for the Learning and Developmental Disabilities Evaluation and Rehabilitation Services, and it was a program that was designed for children, adolescents, and adults, so through the lifespan, basically. And the goal was to provide a multidisciplinary approach to what has now turned out to be a much more complex disorder than I think was originally appreciated. So beginning with the Diagnostic and Statistical Manual that was published in 1994, with which everybody, I suspect, is well aware, the diagnosis was included in what was then called the pervasive developmental disorders, and included autism, Asperger's, Rett syndrome, childhood disintegrated disorder, and pervasive developmental disorder not otherwise specified, known as PDD and OS. And this nomenclature remained for many years and is something, frankly, that many people, despite changes now, to some extent still use. In 2013, a committee came together to revise this protocol and came up with a revision to the nomenclature. And at that point, then Asperger's was removed as a separate entity and was included in the overall label of what now has become the Autism Spectrum Disorders. And I suspect this was an effort to express the fact that this is a complex disorder with multiple different presentations, but that in fact it all is sort of a bunch of subgroups within a larger spectrum. So the Asperger's now is subsumed under the overall nomenclature of autism spectrum disorder. Autism is now being categorized as mild, moderate, and severe, and this is designated within the Diagnostic and Statistical Manual. There is also a new category that's called social pragmatic disorder, and quite frankly, many of us were concerned with this came out because this would be, if someone were so labeled, particularly a child or an adolescent who had been previously called PDD and OS, would this then remove them from the autism spectrum and therefore limit the kinds of services that they received? I personally have not seen that happen, but it's always been a concern, and maybe in retrospect, not a concern we should have been worried about. So, but anyway, the whole issue then became whether how given this change in nomenclature might impact on the service provision for those receiving these services, and what about clinical research going forward, so that if in fact someone decided to conduct some research on a clinical group, how are they going to compare the samples, the patient samples, now that the nomenclature had been changed? So I think so far people have been managing to navigate that system, but it is challenging since we don't have the same nomenclature against which we can compare groups. Nonetheless, we are now working with this newer model, and so far it seems to be working fairly well. The core features of autism, however, even with the change, has remained very much the same. The impaired social interaction, delayed and disordered language, and isolated areas of interest. And clearly there are other associated signs and symptoms, but these are considered the core features. Inconsistent findings, I guess, would be this listing here. And not all people on the autism spectrum exhibit all of these symptoms, but they are a characteristic of many in the group. So, for example, atypical prosody or intonation in the voice, either of the patient, him or herself, or their ability to understand the intonation of other people's voice and what that might mean to them socially. Echolalia, so echoing what other people say, scripting, so taking information that they've heard elsewhere, usually on some kind of TV program, pronoun reversals, and can be more characteristic of some people and not others. The need for routine, difficulty with novelty, and if there is some routine, sometimes anxiety can result from that. Hypotonia or poor motor coordination. Atypical information processing has been documented by many, and certainly sensory dysfunction. When we started looking at infants and toddlers, there are a number of groups now that are looking at what's called the Baby Siblings Project. So this would be younger children of older siblings who have been diagnosed on the autism spectrum. And the reason to look at this was the fact that there is now data that indicates that these children, these younger siblings, are at high risk. The estimated risk factor is approximately 18 to 20% as of this time. And so the effort was therefore, how can you take these individuals from birth going forward, and would we be able to identify possible clinical signals that would give us a clue to identify these high-risk babies much sooner. So we looked at a number of areas of possibility, and one was what we came up with was what we called the socially serious baby. So in other words, the child who, despite everybody's efforts, really found it extremely difficult to get this baby to smile. And this could be in the first 3 to 4 months of life, for example. A decreased social reciprocity. Usually infants are pretty social. They look back and forth, they smile when you smile, and so forth and so on. So some of these babies do not do that. Limited babbling and vocalizations. No pointing or communication at 12 months. So there are many children who go through that who ultimately end up on the spectrum. The absence of joint attention. So the looking, look at the dog and you're trying to point and show the animal to the child. The child's not paying attention. It doesn't share the same area of attention that the adult is. Limited or absent imaginary play. So we're talking about very routine play, running a car back and forth, flying an airplane through the air perhaps, but nothing changes. The scenarios don't change. Visual gaze, many parents, one of the first things they notice is that the child isn't looking. They don't respond to their name. They don't respond to no, they don't look at the parent who's calling their name. And the presence of head lag. Head lags was something that we came up with as part of our Baby Sib project and has been published in the literature. What we noticed was that typical infants will have a head lag when they're born. When you put the baby on his back and pull him to a sitting position, these babies, newborns, typically do not have enough strength or muscles control around the head and neck so that they actually bring that head up when you pull them to sit. And so they have this head lag, and when they finally get to sitting up, the head then moves forward, and then when sitting for a while will flop forward because, again, a lack of head control. Usually head control is established in most typical children by the age of 4 months. And what we noted was that in some of our Baby Sibs, this head lag did not establish itself until around 6 months of age. And thus we felt that this could have been or might be an early signal for children on the autism spectrum, particularly in this high risk group. And this was, as I said, reported in the literature. I don't think this should be taken that every child out there who has a delay in head lag is going to turn out to be on the spectrum. But I think if you have a younger sibling who exhibits this signal, certainly this is a child who needs careful monitoring over time to be sure that he or she continues on a normal developmental trajectory. As part of the Baby Sibs project, we also looked at atypical motor patterns in terms of either sitting or crawling or ultimately standing. There was also a response to maternal still face that we used, and this would include the mother standing in front of the baby, engaging with the baby, making sounds and so forth. And then we asked the mother to stand in front of the baby and totally go blank, but there's no facial expression, no sounds, no anything. Most typical babies would get very concerned about that, want to try to re-engage. The mother would start moving their arms and legs when making noises, looking at the mother, why are you talking to me, so forth and so on. the children who turned out to be on the autism spectrum appeared to care less. They did not, they didn't get to concern. They just began to look elsewhere and just really seemed to be unable or unwilling to participate in anything. So we felt that this was a reasonable signal that we should at least be investigating. Well, the third sentence here has to do with, is this baby like the last one? And when we're interviewing a mother about what her concerns might be about the baby that we're evaluating, we will say, what are your concerns? And oftentimes we'll get a mother who says, this baby feels like the last one. And you'll say, what does that mean exactly? And oftentimes they'll say, I don't know what that means exactly, but it just feels like the last one. So there's this innate concern that this baby just looks very similar to what this mother has been through before. And oftentimes that is a reasonable predictor that this mother has an instinct that this baby may have some difficulties, even in a very young child under 6 months of age. Right now, the current status is that early diagnosis probably can maybe be made maybe as young as 12 to 14 months, although there's a lot of controversy about that. And without a biomarker, however, I don't think that at least we're able to come up with any solid diagnoses prior to 12 months of age with any reasonable certainty. The general consensus among the research world, however, is that diagnostic stability probably isn't going to be established much just before the third birthday. And what they mean by that is there's a good deal of variability in developmental parameters, even in typical children. So even if you have a baby who's got, say, delays in speech and language delay, that may not really mean that he or she is going to be on the spectrum. They may have another problem, or they may simply just be delayed in their speech and language. So the world is basically saying, no, we can't be absolutely certain beyond a reasonable doubt that this baby is going to be on the spectrum until he or she is close to their third birthday. And of course, then this is a problem in terms of getting early services. So there remains this very significant push towards coming up with some kind of a biomarker so that we can establish a diagnosis as early as possible and initiate services sooner than we are often able to do now. Possible causes of autism are many. The general consensus is that much of this is genetic, although we do not have definite genetic markers for children on the spectrum in most cases. Perhaps in 20 to 30% may have a confirmed genetic identity, but not always. And I think genetics is improving, the technology is improving and expanding, and it may be as we become smarter down the line, we'll be able to identify more of these markers, but right now we don't. And epigenetics, which of course has something to do with genetics, is an important factor, which is also variable. Might there be some issues about infection? And there has been, for example, some literature early on when German measles, for example, was a major area of concern. And if the mother got German measles, there seemed to be a high risk of having children on the spectrum as a result of that maternal infection. Currently, given our present COVID-19 crisis and mothers now producing babies, regardless of the virus that is going through the world right now, there's a good deal of interest about what those babies are going to look like, and is this going to have an impact on the developmental trajectory of those babies who are developing during this era. And that will be an interesting area to pursue. Environmental factors, many people have concerned about certain toxins in the environment, what are called endocrine disruptors. So these are medications or other substances in the environment that impact on glands such as the endocrine system, such as the thyroid in particular, for example. Older paternal age has been reported to be a high risk factor. Prematurity has also been another factor. So there are a number of other reasons, and one of the questions is still out there is whether these environmental factors are laid on top of some kind of genetic risk that we have yet to identify, or is it just the environmental factor by itself? And I think that remains not yet determined. There's some very excellent research going on at UC Davis in California, looking at the immune and autoimmune factors, and there appeared to be a subgroup of babies who are born to mothers who have autoimmune disorders like rheumatoid arthritis or lupus, for example, who seem to be at higher risk for autism spectrum disorder. So ultimately, the current consensus is that this is a heterogeneous disorder. It probably has multiple causes. Clinically is certainly quite variable. As a result, biologically, it seems to be variable. And certainly, as we've already said, the causes seem to be variable. So it is extremely complex disorder and challenging for those trying to make diagnoses, understand its underlying neurological mechanism, and certainly to provide treatment. This is far from a one-size-fits-all disorder. So beginning with then, how are we going to go about evaluating such a child, and what kinds of medical and comorbid situations might we be concerned about? I've put that at the top of this title, this slide, a neurologic assessment of the child. And I think largely that's because I'm a child neurologist, but it certainly doesn't have to be a neurologic evaluation. Many of these children are seen either by their primary care physician, by a developmental pediatrician, or indeed by a child neurologist. So there are a number of providers who could be playing this role. In any case, the child is seen by this provider for a medical history and a developmental history, and undergoes an evaluation through some kind of in-person mechanism assessment, looking at all the things that we have already highlighted: eye contact, sitting, rolling over, vocal sounds, interested in toys, and so forth. Then one often is asked what other studies one can conduct that might verify the diagnosis. Chromosomal studies on DNA analysis certainly is often used. It's not necessarily very helpful, particularly because not all of the genes that we think might be involved are identifiable at this time, but it might be helpful for other family members. And a good geneticist would be someone who might be involved here to look at the child and possibly recruit other family members to be involved. Should one conduct an electroencephalogram initially? Probably, in my view, not right from the beginning, unless there's some signs and symptoms that this child has a seizure disorder. I don't think that putting a child through an electroencephalogram early on is necessarily needed or helpful. Similarly, a cranial MRI or an imaging study of the brain is also not terribly helpful unless there seem to be some other early problems, such as potentially prematurity or some head injury, for example, or some kind of illness that may have contributed to some identifiable gross abnormality of the brain. However, even though we might find some abnormality in this brain, it probably will have little effect on what actually what services this child will actually get in order to make developmental progress. And then, of course, there are some issues related to metabolic disorders. Are there some underlying biochemical abnormality that is contributing to this child's profile, or developmental delays? And we'll talk about that in a little bit. So frankly, what one does from the beginning is really to try to get a history and look at the profile of the child, both historically and medically and physically, and then from there to try to get services for the child. Some of these other measures may be involved at a later date. So the question then is, we've done what we traditionally do, which is to get the information I just described above, but are we missing something here? And I think one of the things that we've been missing are this issue of medical comorbidities. It's only been in the recent 5 or 10 years, I would say, that we've really started to appreciate the fact that many of these individuals have comorbid medical conditions that have a negative impact on the person's developmental progress, and are important to not only identifying and treating them, but also potentially helping us understand the underlying neurobiology of these really complex disorders. So what are we missing? Well, one of the things that we got into very early was this issue of atypical or disruptive behaviors. And for a very long time, people have simply seen this as it's just part of the autism. You know, don't worry about it. This is, you know, he or she is acting in a peculiar way. He's running up and down stairs. He's hitting, becoming aggressive or whatever, but this is just because he's autistic. And we began to really scratch the surface about that as to, is this really true? Or is this an otherwise nonverbal child, or a child who, for whatever reason, can't really express to him or herself, who's exhibiting some symptoms in the only way that they can, which is in terms of disruptive behaviors. So we began to look at what do behavioral abnormalities tell us in any organism. And the definition, when you look at it in the dictionary, is that the organism behaves in a reaction to social stimuli or inner needs. So is there something going on, or is there something going on in the environment that's triggering these behaviors? Therefore, these behaviors that we're seeing, are they response to something internal, or are they response to something external? And if, in fact, they are there, is this something that they're telling us about how the organism, in this case the child, is going to respond to these stimuli, be the internal or external. So what do we know about behaviors in typical children? Well, we know, for example, that typically developing children will exhibit odd behaviors, whatever those might be, if they don't feel well. So, and frankly, that's also true of adults. Some of us get very grouchy if, in fact, we don't feel very well, and we can be not very cooperative. So physical illnesses are very common in individuals who have a variety of developmental disabilities. And there seems to be some literature to suggest that those who are developmentally disabled, for whatever reason, seem to have a higher, although the reason for this is really not totally clear. So what medical conditions have been documented in, we're just talking about individuals who have developmental disabilities in general. Problem behaviors have been linked to constipation, allergies, premenstrual syndrome, ear infections, and urinary tract infections. There are probably many more that aren't even on this list. So if you're just not feeling well, you're not going to do well. And the plausible explanation for this is the degree of pain and discomfort that the person's experiencing, rather than the physical illness itself. So just because you have allergies doesn't mean that's automatically going to be associated with odd behaviors, but because you don't feel well because you've got an allergy may make you not behave the way that you ordinarily would. Okay, so many of the common medical conditions that are associated with individuals on the autism spectrum are listed on this slide. And this is certainly not a comprehensive list, but probably are some of the more common ones that we are concerned about, and I will make brief summary about each one of those. So we're talking about seizures, sleep disorders, gastrointestinal dysfunction, metabolic disorders, anxiety, and urinary tract disorders. So if we talk about seizure disorders, there can be a whole host of different seizure disorders, and there are no specific patterns that seem to be associated with the autism spectrum. So we can have just staring spells, we can have major motor seizures, we can have a combination of these seizures. Unfortunately, at least by report, some of these can be difficult to diagnose. Certainly there's no difficulty diagnosing a major motor seizure, that's pretty obvious. But if a child simply presents with, quote, staring spells, quote, there could be a host of reasons about why the child might be staring. So if this is in fact the complaint, it may not be obvious as to whether this is or is not seizure related. So the next step frequently is to obtain an electroencephalogram. The traditional electroencephalogram lasts maybe about an hour, and if in fact the seizure, the EEG is negative at that time, it may not rule out seizures because you simply may have missed an episode, for example. So we have traditionally gone to longer EEGs, frequently over a 24 or 48-hour period, if possible. Now the challenge here, of course, is trying to get the child who has sensitivities, for example, to touch, to wear the electrodes for that period of time. Fortunately, in many cases, we've been reasonably successful in doing that, but it is challenging to get that child or adolescent to do that if in fact they are super sensitive to having things on their head. In any case, this gives us a better chance of trying to pick up an abnormality. That said, however, there can be individuals who have a seizure disorder whose EEGs may be totally normal or at least not reflect any kind of seizure activity at all. And this may be because the focus of the seizure is down deep in the brain and is too far away for the electrodes to pick up. You can also have individuals who have odd-looking EEGs and things that can look seizure-like, who in fact may never have a seizure. So the EEG can be helpful as long as it's correlated with whatever the clinical features might be. My personal favorite is to try to get the family to obtain a video of the event when it occurs. Now that's obviously challenging, except for the fact that most of us carry a cell phone on which we can capture something, particularly the children who present some kind of staring spell. This often happens multiple times during a day, for example. So a teacher or a speech pathologist or a parent might be able to capture one of these events on their cell phone and be able to show that to the provider. And personally, I found that extremely helpful because oftentimes the family or a provider, a speech pathologist or whatever teacher, is describing an event to me, and I think I understand what it is they're describing. And then when I see the video, I realize that I have misinterpreted what this individual has been trying to tell me, and that in some cases, what they've described is not a seizure at all. It's something totally different. So I think that if it's possible to get some kind of video, this is extremely useful. It should be something that most people can easily do on their cell phone. Sleep disorders are extremely challenging because if the child's not sleeping, probably the rest of the family isn't sleeping either. So this is a very stressful situation for all families. Some of this can be brain related in terms of sleep cycles and establishing good sleep patterns, for example, but some of it may be related to other factors. So for example, gastrointestinal reflux disorder. So when one lies down and to go to bed at night, for example, gastric acids can slither up into the esophagus, into the back of the throat, and can wake people up or can cause them to have difficulty getting to sleep in the first place. So it would be important to be sure that this is not something that's contributing to this disorder. Allergies can also be a significant problem, particularly if they affect the sinuses, or one has a large tonsils and adenoids, which then impact negatively on the ability to breathe efficiently. If you can't breathe well, you're probably not going to sleep well. Sensory processing issues can also be challenging. Many children, adolescents, and adults like deep pressure. There now seems to be a big push for even the typical population to use what are called weighted blankets, with the idea that this additional pressure can aid with sleep onset, and that certainly can help this population as well. So there could be a number of reasons why sleep disorders can occur, and again, it's a matter of trying to figure out what the cause is in order to find the appropriate treatment and intervention. Gastrointestinal issues, we've already touched on a bit. Having a very limited diet is fairly common with this population. There's sort of a joke running that the typical diagnosis for an individual on the spectrum is pizza, French fries, and chicken McNuggets. And not too much in the vegetable department. Some kids seem to avoid meats. Fruits seem to go pretty well, but in any case, it's fairly limited. Constipation and diarrhea can be fairly common. Abdominal pain can be common. Some of these children have cyclic vomiting. And then there are some children who, because associated with their constipation or what appears to be constipation, can have a tight rectal sphincter. And clearly these are kids that really need to be seen by a gastroenterologist. And I would urge you to find a gastroenterologist who is familiar with working individuals on the spectrum, because most of these individuals, be they children, adolescents, and adults, don't typically present with signs and symptoms that the average practitioner or specialist might recognize. So for some of the signs and symptoms that we've come up with so far that individuals on the spectrum present with are on this list. So we can see somebody who has odd facial grimacing and gulping. And that may be their total presentation, that this is just odd movement. So this is not just autism. They're telling us something, and this is frequently seen in individuals who have reflux. Tapping on the chest or stomach, so they've got irritation or discomfort in their stomach, putting pressure on their abdomen. I've had a situation where a young adult came into the office and immediately headed for the sink and put pressure on his abdomen, and it was quite clear that this was probably a gastrointestinal component based on other information that we had, which turned out to be the case. Constant chewing on not edible items such as shirt sleeves, the necks of shirts, other toys, for example, a chewy that many children are given, pacifiers and so forth. And the theory here is that if you have some irritation in your esophagus, what you're doing is creating extra saliva by chewing on these items, and the saliva then is causing a soothing effect in the esophagus, which then basically treats the irritated esophagus. So again, if one sees this, one has to think about possible reflux as a cause. Frequent eating and drinking would have the same idea here, that if you're constantly eating and drinking, you're again creating saliva or comfort in the esophagus. So at this point in time, frankly, when we see individuals who come in with negative behaviors, so they could be aggressive, they could be self-injurious, they could be running around, they could be non-compliant, there could be whole numbers of behaviors that these individuals can present with, particularly if these are new behaviors or people haven't been able to control these behaviors using the usual means, then one needs to refer to a gastroenterologist. I think this is common enough. There's a lot of debate about what the actual prevalence of gastrointestinal disorders are in the autism community, but it can be as high as 80% in some studies. So I certainly considering some kind of associated gastrointestinal disorder is warranted, but it must be referred to someone who has had experience working with this population, otherwise it's likely to be missed. Urology or nephrology, so urinary tract stories, certainly they can have a urinary infection just like anybody else can, but there are also seem to be a subgroup of individuals, usually in the pre-adolescent years has been our experience, where they've been toilet trained and suddenly they become incontinent. And somebody says, well, this is a behavior. Well, it might not be a behavior because as it turns out, many of the urologists with whom we've worked have diagnosed some of these children as having a spastic bladder. Why they develop a spastic bladder, I don't have any idea, but they do seem to do so. And when this is diagnosed, it can be treated with, in this case, I put ditropin here, but there are a number of other medications. This is a treatable disorder, and it should not simply be seen as a behavioral non-compliant issue. At least somebody needs to explore the possibility that there is a medical or neurobiological cause for this before one assumes that this is just a behavioral issue. So then we talked briefly earlier about metabolic disorders. So there can be individuals, and I think there is in fact a growing literature now and interest in metabolic disorders, particularly what are called mitochondrial disorders. Mitochondria are the inner engines for every cell in your body, and they can play an important role in how the organism functions on a day-to-day basis. And so we have started to look at what we would call our clinical red flags. What would make me as the provider consider the possibility that there might be an underlying or associated mitochondrial disorder? And these are some of the ones we've come up with. This may be only a short list, and there may be other potential markers that we haven't even thought about yet, but these are the ones that we think that we've identified. And this would start with poor physical endurance. Individuals on the autism spectrum seem to have enormous energy for all kinds of things. Little kids, I wish I could clone their energy, but they're just constantly on the go. If you have, on the other hand, you have a child who, when you go to the mall or you go out for a walk or whatever, wants to be picked up and put in the stroller or carried, that's really pretty unusual. And I think one would need to think seriously about whether or not this is real or not, whether this might have some kind of underlying physical problem. Late walking, most of individuals on the autism spectrum, despite the fact that they can have low muscle tone and perhaps some difficulty with coordination, usually walk on time. if you have somebody who hasn't walked independently by the time they're 24 months of age, that's really very odd. And that's something that probably needs to be further investigated. We're fairly commonly used to hearing the story about how a child on the spectrum has gone through a period of regression, usually language regression, usually under the age of 2 years, somewhere around 18 months to 2 years of age is a fairly typical story. If, on the other hand, you have an older child who is going through repeated regressions year after year, so it could be 2 or 3 times a year that they lose some skills, then they come back, and then they lose some skills, they come back, and so forth. That is very atypical and definitely deserves further evaluation. Children who have dysmorphic features certainly deserve a genetic workup, if not a metabolic workup as well. Making poor progress in a program or with services despite the excellent services. So you can have children who are receiving 40 hours a week of intensive ABA services, speech and language, and the whole host of other interventions who just are not making any progress. And one has to really ask for yourself, what's holding this child back? Why is he or she not making the kind of developmental progress that, given everything we're doing here, is not making the kinds of gains that we would hope? Then we have the child who, I guess one would have to say is kind of hard to describe. The child who is qualitatively different. The child comes to the provider and yeah, he or she meets criteria for autism, but there's just this underlying intuition, if you will, that there's something a little bit different about this child. And it's very hard for me to describe exactly what I mean by that, but I think that people who have been in the field for a while know what I would be talking about, that there are certain children that just kind of don't fit into the nice little niche that we think about diagnostically and merit further investigation. And then lastly, the involvement of multiple organ systems. So this is just a child who presents not just with his or her developmental delay, but indeed has a bladder problem, or does have gastrointestinal concerns, or does have allergies or sleep disorders or what have you. That this is involving much more than just the brain, that there's something else going on here. And this is a child who would merit a much more in-depth evaluation. So as we talked about earlier, that we have become very interested in mitochondrial disorders, and in 2008 published a paper where we described 25 clients. And what we were looking at is, could we use the red flags that I previously described, and could we then diagnose these individuals and treat them? And if we did that, what would be the result? And so all of these individuals that were published were individuals that had confirmed diagnosis of a complex 1 or complex 2 mitochondrial disorder based on muscle biopsies. And many of them presented clinically with non-neurological medical conditions. So it could have been the delayed walking, or it could have been lack of physical endurance, for example. So it doesn't necessarily have to be that they present with seizures or some other obvious neurological issue. 19 of the 25 subjects had constitutional symptoms, primarily excessive fatigue, which I've already mentioned. This is just a listing of some of the things that we saw, unusual patterns of regression. The lactate and the alanine were abnormalities on the blood test that we did. There were abnormalities of liver function studies. And we were also looking at what kind of complex disorder would they be involved with as it related to the mitochondrial diagnosis. Initially, these subjects were all identified as having ordinary garden variety autism. However, as we began to probe them for these red flags that we were looking for, it was clear that they were not part of this idiopathic diagnosis. And finally, when we ultimately got through this assessment, it became clear that there was at least a subgroup of individuals on the autism spectrum who had what best could be described as an associated mitochondrial disorder that was underlying, or at least causing some of the symptoms that we've already described. There has been some recent literature now that is tying the mitochondrial disorders in autism to those children who have gone through a period of early regression, but the kids who are presenting at 18 to 24 months of age. And there appears to be a growing literature that's supporting the possibility that those regressions may be related in some way to some deficiencies in the mitochondrial system. So switching from metabolic disorders to psychopharmacology, there are many individuals on the autism spectrum who present with a number of, for lack of a better term, I guess, psychiatric disorders. So it's sort of one of the more common ones is anxiety. Certainly attention deficit would be considered in this category, some with depression. Some have been diagnosed with bipolar disorders. So there are a number of things that a psychiatrist might need to be involved in. And certainly lots of times these children are referred to the psychopharmacologist because of their disruptive behaviors or self-injurious behaviors, with the hope that some kind of medication can be employed to control or correct these behaviors. So starting off, my personal opinion about medication is that before one launches into simply throwing medication at a child, adolescent, or adult, one has to be sure that you've ruled out any kind of potential medical causes first. Certainly if you have a behavior problem that's on the basis of a medical condition and you haven't treated the medical condition, no amount of psychotropic medication is probably going to help you. So for example, I've had a girl who came to the office who was hitting her head and saying, "Head hurts." It was the one thing she could say. And the implication was that she had headache. At what point we played a different game here, sent her to the gastroenterologist. She turned out to have gastritis and esophagitis. This was treated, and no more did we hear about head hurts, and there was no more head banging. So what I think was going on here was her means of saying, "I don't feel well." It didn't necessarily mean that her head hurt. So this is an example of wanting to go beyond the obvious and to try to figure out what's the underlying cause of some of the behaviors with which these folks present. I don't think that medication management should be the first line of defense, and I think it certainly can be extremely useful as an adjunct to many other interventions, but I don't know that one automatically wants to just dive into medications without approaching other means. What specific symptoms? We've talked a little bit about the depression, anxiety, OCD behaviors, impulsivity, attention deficit disorder. There can be a host, and absolutely the psychiatrist needs to be involved. When coming up with medications, we need to talk about the risks and benefits of choosing any one of these medications, and as well as what other signs and symptoms exist, and whether or not what the medication we choose are compatible with some of the other potential medications or treatments that the child or patient is receiving. So when choosing a psychopharmacologist, I think the family possibly needs to interview a couple of people because they need to have someone that they're comfortable with. There are all kinds of, and this is probably true for any provider, quite honestly. I always frequently tell my families, you need to work with somebody that you feel comfortable asking what you would consider a fairly stupid question, and this person is going to take the time to answer whatever that question is. That you're going to be able to talk to this person frankly about your concerns, and they're going to listen to you. The choice of medications can be influenced by the training of the provider. So in some institutions, some medications are typically used and other less so, depending upon where the person is trained. Sometimes the healthcare insurance can influence the choice of medications. Some of the healthcare insurance will cover one medication and not another. And then there's the issue of considering the medical risks, the cost to the patient. Do you have to do invasive procedures to measure, whether your dose is correct, for example? Do you have to do EKGs on them, cardiac exams because of potential side effects? So there are a number of questions that one needs to be asked when considering a medication option, all of which need to be addressed at any point when you're considering medication management. So other medical conditions that we haven't talked about and we won't spend a lot of time talking about here is certainly obesity. And we see a good deal of that in the autism population, potentially because many of these individuals are very strong eaters of carbohydrates. Oftentimes they're not very athletic or active, so this could be a high risk area for that. Osteoporosis is sort of a new area of concern in the sense that many of these individuals are on restricted diets. and their access to calcium is limited. So one has to be very cautious if one's going to use some of the, for example, gluten and casein-free diet, that one comes up with another mechanism to ensure that the patient is receiving other sources of calcium. Otitis media, ear infections, can be very common, can be also easily missed unless someone figures out that maybe there's something going on there, or at least looks. PANDAS, most of you know what that is. That's a response to strep infections, believed to an immune response to strep infections. There's a good deal of literature about this coming out of the NIH, headed by a lady named Dr. Susan Swedo, and is also treatable, but sometimes can be challenging to diagnose. Certain parts of the country can be associated, have a high risk of what's called Lyme disease. This is usually due to a deer tick. And so people who are out camping in the woods, or going on hikes in the woods or something, particularly in certain parts of the country, might be susceptible to Lyme disease. The disorders can present with behavioral problems or OCD behaviors or anxiety. So oftentimes they'll present more as a behavioral issue than a physical issue. Dental problems, children who are having trouble with their wisdom teeth may have cavities. Oftentimes it's difficult to brush their teeth, so it's possible that cavities could develop and cause pain. So that's another area to look. And then certainly injuries and fractures. Oftentimes the children who have some of these injuries can't tell us that they actually have the injury, or do a very good job of locating for us. So again, these are all areas that we have to sort of think about if somebody is presenting with some odd behaviors that we can't explain any other way. So the Ladders team, getting back to the story about the fact that we've just presented a very complex picture here of individuals on the autism spectrum. And this goes well beyond just, we're going to give him applied behavioral analysis. We're going to put him in a good classroom. We're going to try to treat these behaviors with some kind of medication story. This is much more complex. And therefore, it's really going to require a group of people with different backgrounds to try to address some of these issues in a much more coordinated way. So we came up with the idea of a multidisciplinary clinic to try to address some of these complexities. And as we said early on, these individuals on the autism spectrum are not the same. This is not a one-size-fits-all disorder. What works for child A doesn't work for child B, and so forth. And so we have to be very creative about trying to figure out what kind of individualized services we need to be provided to this in one child who's in front of us. So we need the right intervention for each child. We need the right approach, and we need many perspectives to determine and guide the effective services for each patient. So what people should be making up this team? Well, this is the team that we came up with. People might be able to come up with their own teams in other environments. Child neurology is where we started, but we then recruited an adult neurologist because we're now got to the point of treating children, adolescents, and adults. Psychiatry, same thing, child and adult psychiatry. Developmental pediatrician, internal medicine, gastroenterology, needs again to be somebody who understands those on the spectrum. Neuropsychology, because we need someone who's capable of evaluating individuals on the spectrum. This is a challenge by itself because of the fact that many of the measures that are used for evaluating individuals from a neuropsychological perspective are very language loaded, and many of our patients have difficulty with language. So how can one try to figure out how to accurately assess the intellectual capacity of an individual on the spectrum? How can you define their areas of strength and weakness? How can you define their best learning style so as to guide educational and other kinds of interventions going forward? An education specialist also became part of our team because we really needed someone who could also evaluate these children from an educational perspective, but more importantly, to work with school systems in order to ensure that the patient in question is receiving appropriate services within the public or private schools, whatever school system or school program this child was in. Frequently, we will ask this person to make a school visit, to go sit in the classroom to actually see what is going on in order to really get a better feel for what seems to be working well for this child or what seems not to be working well for this child, and what could be put into place to revise it so that he or she could benefit better from the program being provided. So all of these people can be a very important member of a core team. Other members that we've used are the social worker. The social worker often is involved in performing the intake activities, gets the parent who is applying for a visit to the clinic, meets with the social worker, usually over the phone, to get the history, and the social worker getting that history is then able to guide the referral to the appropriate providers. A family resource coordinator is somebody who is in critical need, at least in our program, because it is one thing to do an evaluation on the patient in front of you, but it's quite another thing to help the family find the appropriate resources in the community where they live. Our program was such that we received referrals not only in our local area, but from other parts of the country and certainly out of state. And we had to be able to have somebody who had contacts and other connections who could help us find an adequate qualified speech pathologist, for example, near where this patient lives, or someone who could do occupational therapy or a good school program or what have you. We can't simply say to the family, go find a speech pathologist. That just isn't going to work. We need to find somebody who is going to be the right match for the patient in front of us. Likewise, for occupational therapy, we all know that now that a lot of these children, individuals on the spectrum, I'm talking about children, but I hope you all realize that I'm talking about children, adolescents, and adults here, that have sensory processing concerns that can be causing anxiety. We can talk about fine motor skills that can be deficient, gross motor skills that are deficient. Same thing for physical therapy. A lot of these folks have low muscle tone, poor core strength, which finds it, and so they find it challenging to sit, for example, for long periods of time, which is fatiguing for them. Speech therapy is certainly an area of grave concern because this is well known to be part of the spectrum, that these children, adolescents and adults may have trouble with expressive language, but they can also have trouble with receptive language and pragmatic language. Social communication skills can be challenging. Audiology, we certainly want to be sure that they're hearing okay, but also there's the issue of what's called central auditory processing. And what we mean by that is as the length and complexity of language increases, particularly in school after, I would say, the second grade, for example, teachers are giving multi-step commands. Take out your math book, turn to page 32. We're going to do the first 15 problems, but only the odd one. This may be a child who gets out his math book and then is lost. And this could be interpreted as having an attention deficit disorder, but in fact, it may be, excuse me, that his brain is simply not processing this information very rapidly, and we'll need to have some mechanism of accommodations in the classroom, as well as some specific strategies. Clinical manager and nurse is essential to a program like this, so that again, this is a coordinator. So who is going to coordinate all of these services and to help this family organize all the things that they need to do? Lots of families can get totally overwhelmed by the multiplicity of interventions and services and appointments and school programs and negotiating with the insurance company and so forth. Somebody has to be there to help them negotiate all these different sites. And it's our hope that the social worker, the family resource coordinator, and certainly the nurse all could, or one or the other, could be involved in providing that kind of service for their family. Now, clearly not everything that's needed here can be encompassed into any kind of a program anywhere. It's just too complex. But we need to establish relationships in the community with other providers that we have confidence that we can send somebody to who understands this population and will provide the kinds of services that we need. So we've got to find a good dentist. How are you going to get an autistic individual into the dental chair? A lot of the dentists now that are working with children with special needs have various methods of doing this. They will have their children come and visit the office for a period of time. They'll have them sit in the chair. They won't do anything. They'll let them touch all the instruments and so forth, trying to get them used to the environment. So one needs to identify an appropriate dentist, for example, who would be receptive to seeing individuals with challenging behaviors. A behavioral psychologist, absolutely essential, providing research consultation to family members, combining programs to school systems. This could be an ABA person, a board certified behavioral analyst, parentheses BCBA, for example. Or it could simply be a behavioral psychologist who's providing other kinds of behavioral therapies. But oftentimes just providing families with strategies to treat some of these behaviors that are stressful at home can be enormously helpful. And this person can work either in the school or at home or in the community to help families and this child. Orthopedics, we have children who have been toe walkers, for example, who can use orthotics to get those heels down until we train them to do otherwise. We can have certainly children who have odd gait patterns, children who have other orthopedic needs that need to be addressed. Endocrinology, oftentimes there are children who do have thyroid problems, but also premenstrual syndromes, or particularly teenage girls, can be extremely challenging. They have a lot of trouble around the times of their menstrual periods. They can cause severe behaviors. And we found that some of our endocrinologists will discover that some of these girls have had imbalances in their estrogen and progesterone levels. And if that can be rebalanced, that many of these disruptive behaviors or difficult behaviors can be remediated. We've talked briefly about medical genetics, and much of that certainly should go on, because every year it appears that the technology is improving in that field, and I think it's something that continues to be needed and followed. Ears, nose, and throat specialists, absolutely. We've got children who've got large tonsils and adenoids, and we talked about that when we were talking about sleep. Developmental optometry and ophthalmology, and this is a tough one sometimes because this is not always obvious, but there can be children who have difficulty with depth perception and therefore seem to be a little more cautious on doing anything that's got to do with motor skills, or difficulty with visual tracking. In order to be able to read across the horizontal part of a page, you have to have reasonably smooth visual tracking. Or if this is somebody who's nearsighted or farsighted or has an astigmatism, any of these kids can have any of those things, and those need to be evaluated and addressed. We talked about sleep disorders, and there are sleep specialists who can be brought into this. Nutrition and dietary management can be helpful. We talked about urology and nephrology. Assisted technology is huge right now, particularly for a lot of the children who are nonverbal. Just because they're nonverbal doesn't mean they don't know what's going on, and some of them become very frustrated because they can't communicate their wants and needs very well. So providing them with some kind of communication device can be essential. There are many devices that are available, and I think it is important to try to find an assisted technology specialist who can do an assessment to decide which device it would be most appropriate for this child at this particular stage of their development, while still providing ongoing monitoring so that devices can be upgraded as the child improves and uses whatever device that they have or need. So these individuals are extremely important and have really changed the life for a lot of children and adolescents and adults. Legal assistance can be frequently needed, sometimes in terms of finding medical coverage, but more importantly in terms of finding and trying to help families obtain appropriate educational services for their child. It's difficult to bring in a lawyer, an educational lawyer. One doesn't like to have to take on school systems for that purpose, but sometimes it comes to that, and the real issue is we have to be able to provide appropriate services for the child within the law that's available in that state or in that community. And oftentimes recruiting an educational lawyer can be enormously helpful in order to obtain what the child needs, either in the public or private sector. Parent support groups can be extraordinarily helpful because parents can share information with each other. Who is a good provider for this service that I need? Where can I find a good babysitter? Where are stores that are autism friendly? stores? What movie theaters can we go to where it's autism friendly? So they can be extremely helpful, and I would certainly support the continuation and involvement of any kind of support groups. The 501c3 team means that a clinic like this probably is going to lose money. And how are you financially going to keep this going? You can, yes, insurance will pay for it. Parents can pay to some extent out of pocket for some of this. But this clinic is made up of not only providers, but they're also non-revenue providers. That is people who are important to this team who cannot send a bill. So for example, the family resource coordinator is not a fundable person. We do not send out a bill for the family resource coordinator or the social worker or the clinic coordinator. They don't make money. So a clinic like this is probably going to be a money loser. And this particular clinic probably has lost somewhere between $300,000 and $500,000 annually because of these extra services that are provided that are essential to the core of such a program, but simply have no way to get reimbursed through the means that we usually are getting our payment from. So what we did was we created a 501c3, which was a tax-exempt organization, usually made up of parents and other people in the community, business people in the community, with the idea that they were going to conduct fundraisers of some sort to figure out how they can make up the extra money that we needed to close the financial gap. And that was extremely helpful. This became what was called Friends of Ladders. And they held fundraisers, they did websites, they did got other people, got grants, all kinds of things involved in order to help close that gap. And I think to be able to do a clinic like this, it's essential that some kind of group has to be able to provide the extra financial resources to support these otherwise non-revenue providers who are in fact essential members of this team. So the ladders approach in brief, and again, this would vary with anybody's clinic. So this is our approach, but this isn't written in stone. Usually, as I mentioned earlier, the social worker was the person who usually took the intake information, sent out what we call an intake packet, which would be paperwork that we would ask the family to fill out so that we had some background information, ask them for copies of previous evaluations that have been done elsewhere, so we aren't repeating what's already been done. But if the child has an educational plan, we'd like to have a copy of that so we know what was going on there. And then would schedule an appointment with a doctor that the social worker felt would be the appropriate match given the services requested. The doctor's visit was very much as I described early on. The diagnosis would be confirmed if that was the question, and appropriate referrals made usually to other problems, so referral to the speech pathologist or the occupational therapist or whoever. After these evaluations had been completed, the doctor and the parent both get copies of the report and would then meet again to review the findings and recommendations. So after the evaluations have been completed and the reports have been provided, it's important that the doctor meet with the family, go through the findings and recommendations, and then assist in making referrals outside of the clinic or potentially in the clinic, depending upon what works best for the family. If the family lives far away, then it would go to the family resource coordinator who would then help the family find appropriate resources depending upon what is needed, schools, therapies, and so forth. So what are the advantages of a multidisciplinary clinic, and why are we going through all of this? Well, I think there are many, many advantages. So first of all, each of us learns from each other, the discipline. So as a neurologist, I was not trained to learn anything about speech pathology or what an occupational therapist did, what special education was all about. That was not part of my training. And the only way that I was able to learn that was from the colleagues who were around me, who were seeing the same patient I was, and who could tell me about how they were seeing this child from a different perspective. It was an extremely valuable lesson. It allows us to share our observations and our approaches and to really see what works best and what doesn't work best for any individual that we see. This also provides us with the opportunity of getting sort of an on-site consultation. So if I'm seeing a child in clinic and I have a question about whether I really need to send this child to see a physical therapist, I can simply excuse myself, walk down the hallway to the physical therapist, say, excuse me, would you mind just stepping in for a minute and taking a look at this to tell me whether we need to do a more in-depth assessment or not. So this avoids a lot of extra unneeded assessments if that turns out to be the case, or it allows me to say, okay, yeah, now I've got validation and we really need to do something that's more in-depth. This also avoids the fact that sometimes I might make a call to a referral. So for example, if I called the gastroenterologist and that person's not available and I leave a message and then 3 days later they call me back. Well, then I'm supposed to remember who I called about and what the question was in the first place. And sometimes I'm good at that, but sometimes I'm not good at that. This way I can simply, again, walk down the hallway and ask my question. And then I don't have to go through all this waiting for somebody to get back to me. And it really smooths out and makes it more efficient to conduct the business that we need to conduct. This is also extremely much more favorable for families so that they're not having to go and find services in multiple different sites. So sometimes there are patients who are getting their speech therapy in one place and they're getting their occupational therapist in another place, and then they get educational consultation in the third place. And none of these people are really talking to each other. They don't have the option of communicating and sharing data. And there's also a lot of running around. So we're trying to reduce the risk of fragmented care. We want something that's much more cohesive and coordinated. And from a research perspective, this also offers the opportunity for interdisciplinary clinical research. So that we, for example, when doing our baby Sibs studies that I mentioned early on, allowed us to involve the speech pathologist and occupational therapist, the doctor, the psychologist, whoever that we felt was important to try to figure out what the answers to the questions we were addressing. So it does provide that kind of an opportunity. So based on this Ladders model, in the fall of 2003, I was asked to give a presentation in Seattle, Washington. And this was a meeting that was not directed towards me at all. I frankly invited myself. And I was asked that since I was going to this meeting, maybe I could just present about the Ladders program. And I had at that time assumed that other people were doing very similar kinds of models, which did not turn out to be the case. And the first 5 academic sites are listed on this slide. And these were the ones that first became part of this effort. And the idea was to develop common protocols that we could all share, and then to begin to collect data about what was most effective, what was least effective, and develop a sort of an overall plan for the management of individuals on the autism spectrum. So why would we even bother to want to do this? Well, there are a lot of questions, that some of which I've raised in this presentation so far. So when we were talking about the mitochondrial disorders, for example, we were talking about the diagnostic red flags. Are they valid? Okay, well, we think they're valid, but maybe they're not valid elsewhere. Or maybe there are other red flags that we haven't identified yet or thought about that somebody else has come up with, and maybe they can share that information and educate us. What part of the autism population are affected by, we've already mentioned GI tract issues, or what part of the population is affected by mitochondrial disorders or sleep disorders? We don't really have a lot of solid data with a large population. How can we help be more efficient in teaching other providers to identify some of the medical comorbidities that we're interested in? What interventions are the most effective? Maybe, as we've said many times, this is not a one-size-fits-all, but if we had some kind of protocol, would there be at least some commonalities that we could bring to bear here that would be effective? And then how do we establish some scientifically sound and meaningful standards of care? There currently, even now, are not scientifically sound, meaningful standards of care for individuals on the autism spectrum. It's very spotty, and we still have a far way to go in coming up with that goal. So where are we now? Well, the ATN became a part of a number of different groups, but currently is under the administration of Autism Speaks out of New York. So in January of 2007, and again in 2013, the Autism Speaks initiated a request for a proposal to expand the Autism Treatment Network initiative. And as a result, there are now a total of 14 multidisciplinary medical sites who are associated with academic centers who are participating in this effort. And the sites that I will show you are on the next slide, which include 2 in Canada, one in Alberta and the other in Toronto, and all of the others are throughout the United States. And they all are multidisciplinary programs geared to the evaluation and treatment of children and adolescents on the autism spectrum, some of whom are also treating with adults. The goals of the ATN are to establish evidence-based training data, with regard to medically related conditions, and to establish standards of health care for children, adolescents, and adults on the spectrum. And this is to be done using combined data. So, summary. What about these medical comorbidities that we've talked about? If we can identify them, what's the point? The point is that we're trying to improve quality of care. We're trying to come out with better ways to achieve better outcomes. If you feel better, you're going to do better. Can we identify subsets of persons on the autism spectrum who are medically or genetically or metabolically similar? And if we did that, could we then say, okay, this is a subset, so we know we need to approach them in one way where we might not approach another subset in a different way? So that's one thing we want to talk about. We want to talk about associated medical conditions and how they might help us understand the underlying neurobiology of the disorder. So for example, there is a growing interest in the connectivity between the gastrointestinal tract and the brain, what's called the gut-brain connection. And I think there is a growing appreciation that that is connected, and how can we better understand the underlying neurobiology of both of those systems to give us a better understanding of the disorder as a whole. So where are we going to be going from the future? Well, as I've indicated earlier in this talk, there is a huge need for biomarkers. It would be wonderful to be able to identify a high-risk baby at the time of birth, or certainly in the first couple of months of life, in order to try to initiate whatever interventions we might be able to initiate to improve the outcome and developmental course of that particular child. Can we identify autism subgroups, which we've already addressed a little bit? Expansion of the use of assisted technology. That is moving along, and I'd like to see it move along a little faster. Can we become a little bit better at correlating clinical profiles with some of the studies that we're doing? So for example, if you had common clinical phenotypes or presentations and you were doing imaging studies, or you were just studying the brain under the microscope, would that help you? And this is someone who does some of the brain research. This is often a frustrating story because some group will provide some information based on their studies, and another group will provide a different kind of information. And I don't think that means that one site is doing something wrong or has come up with the wrong conclusions. I think they may be looking at different populations. And since we don't have subgroups, it's challenging. We don't have a lot of clinical data when we're doing some of these studies to make good correlations between what the patient is actually doing and capable of versus what we're seeing under the microscope or on the imaging screen. I'd also love to be able to see some longitudinal studies in the same population, because I don't think that we have a good sense of what the natural life history of this disorder is. What if you look a certain way when you're 3 years old, what are you likely to look like when you're 45? How capable are you going to be going down the line? Are you going to be independent? Are you going to be a college student? Are you going to be taking care of animals in a volunteer kind of capacity? Are you going to be living in a group home? Are you going to be able to live independently or not? We don't really have those kind of data. We don't even have longitudinal good medical data to know what are high risk medical conditions that older individuals on the autism spectrum are likely to have. off the top of my head, I can't think of ever having seen an adult on the autism spectrum who also had multiple sclerosis, for example. They may be out there, but right now, I don't know how you identify them or if anybody's even thought of identifying them. So we have many questions that we need to look at as we look in this aging population. Correlates between the genetics and the clinical phenotypes. One of the major challenges right now and interest is the differences between males and females. And the fact that females now are believed to present substantially differently than males, and that many of our diagnostic markers are really believed to be geared more to males, which means that a lot of the females may be missed. And I would agree with that. Many of them are given, many of the females are given psychiatric diagnoses, such as anxiety or attention deficit or whatever, a bipolar I've seen. And by the time they get to be 20 or 30 years old, suddenly they show up in our office, and there is no question that they are on the autism spectrum, but were never so diagnosed. So I think that this is an area of important interest and something that we really need to spend more time with. We've already talked about the gut-brain relationship. Meaningful employment for individuals on the spectrum. I think this is a tremendously high priority. Many of them are extremely talented. Many of them are very technically skilled. And there are programs now that are being developed largely through the efforts of parents, where many of these technical skills are being put to good use. And these people are doing extremely well in jobs that they're good at, and furthermore, that they enjoy. And then we've already mentioned something about studies for aging, and where are the autism seniors? I don't know that we know where the autism seniors are. I don't know whether many of them were mislabeled, but we're trying very hard to find these folks and to understand a little bit more about what the longitudinal story is here and whether there are specific medical conditions that we need to be aware of in this population as a whole. So finally, there is hope, I think. I think we're making a lot of gains. The situation is certainly far different than when I was trained many years ago. I think we now know that early diagnosis and intervention makes a huge difference in outcomes, which is all the more reason that we're trying to find early biomarkers. We also have data now that shows that there is a subpopulation of individuals who, when given appropriate services early on, no longer meet criteria by the age of 6 or 7. And this is some beautiful work that has come out of the University of Connecticut. But then you have to ask yourself, why these children and not others? And what's the difference between those children and other children who don't have that kind of an outcome? What are the treatment for medical disorders that can help us result in better outcomes? The identification of autism subgroups, I think people are making efforts of that. The question is, how are you going to find subgroups? What are the parameters that you're going to use to define these subgroups? Is this going to be a biological subgroup? Is this going to be a behavioral subgroup? I think that's not settled yet, but again, there is an effort to look at that. Better availability of services, yes, we do, but we're certainly far from perfect, and I think that we still have a very long way to go. And as noted earlier, things do change over time, and there is some growing data to suggest that some of the symptoms seem to improve with age, particularly as we see some of these adults. There are fewer of them that seem to have repetitive behaviors, for example, in adulthood. So again, we need to know what the natural life history is and what that then tells us about the neurobiology of the disorder. So all told, I think that there is a huge benefit for a multidisciplinary approach. This is not going to be a one-size-fits-all. This is not going to be a disorder where one discipline is going to be able to solve the problem. And I think this has to be a combined effort from multiple disciplines to achieve better understanding of this disorder. Thank you.